Thank you very much for the introduction and for the opportunity to share some of the work that we're doing here in Alberta and with some of our collaborators nationally to try to understand some of the sort of key questions around prevention, screening, and treatment considerations for early age and onset here in Canada. I should note before I start that a lot of this is collaborative work, and while I'll be the one sort of presenting it, it's a team effort very much, led or co-led by Doc on our team, Dylan O'Sullivan, by medical oncologist here in Alberta, Dr. Winston Chung, and with some of my colleagues in gastroenterology, Dr. Bob Hilson and Dr. Steve Heitman. And so I just want to sort of acknowledge that this is very much a team effort, and I wanted to acknowledge that. So jumping right into it, when we show what the actual data, what really is the cause for concern here. And so I think that's important to set the stage with what the actual data are here in Canada. So this is some work we did a few years ago to look at the trends in early age at onset cancer in Canada. And so these are what are called birth cohorts, where we compare incidence rate ratios. And so each of these circles represents a group of Canadians, a 5-year birth cohort. So people born every 5 years collapsed together. And to do this, then we can compare the rates over time. So these two panels separate males on the left, females on the right. And what you'll note is that people born post 1960, there's quite a considerable jump in the difference in rates of cancer compared to people born in older historical cohorts. To a point where the youngest groups, so those who are sort of born after 1980 now, have a 200 to a 250% increase in the likelihood of being diagnosed with colorectal cancer before age 50. And so these are comparative numbers to other age cohorts. And so this is really what I think is important to set the stage with, that is cause for concern. And it's important to put this in context too of other trends for different age groups in terms of colorectal cancer in Canada. And so moving away from a comparison to the actual numbers, so these are sort of the diverging trends that we see when we look by age group. And so here are these two panels, they show the absolute rates. So these are the age standardized actual rates per 100,000 Canadians. Each dot is a year. On the top two panels are females, on the bottom two panels are males, and then the panels on the left are among those diagnosed for age 50, and on the right is people who would be sort of considered eligible for screening age presently, so 50 to 74. And what you'll note for the two left-hand panels, so for both males and females, from around the late 1990s, and this corresponds very closely to those graphs I just showed in the comparison analysis, you see a dramatic increase in the rates per year of what we call the average annual percent change. So the rates are continually going up, and this has been statistically significant for several years now. And so that's also interesting because that's directly in opposition to the trends you see in those age groups 50 to 74, where in Canada, we look at the national data, it's been quite successful over the past 10 to 15 years in terms of reductions of incidence, and this also corresponds to reductions in mortality. And we're seeing that colorectal cancer in older age groups is one of the fastest decreasing cancer rates. So it really shows that there is definitely cause for concern and cause for alarm. In terms of additional context for this particular population, so we know that proportionally it represents a much smaller number of cases. So it's only about 10% of the absolute numbers of cases. But as we saw, this number is going up and this proportion is increasing. What we know is that most early age onset, as you heard previously, struggle with diagnosis and they're diagnosed at later stages, typically have more aggressive clinical features. And then from the patient perspective, this translates into a greater potential number of years of life disrupted, disruption to the structure and socioeconomic status of families, and potentially brings with it long-term implications in terms of their general health from treatment. And so this is all to sort of set the stage and to understand that there is a considerable human patient problem here in terms of increasing rates and relative proportion of early onset cases in Canada as well. So the data suggests this problem exists very much in Canada as well. And so, and to try to understand what's going on here and to try to provide some assistance in terms of research, our team in Alberta and with some collaborators across the country have been working to try to use data and analytics to generate evidence and hopefully translate eventually into some patient impact across the cancer, excuse me, the cancer care continuum. And so this includes some work we've been doing all the way from understanding the etiology of the disease. So what are those exposures, those individual factors that increase someone's risk in terms of primary prevention with the goal of trying to reduce the risk of in the population of early age onset colorectal cancer. And then also we've been doing some work around secondary prevention. So once early stage disease has occurred, are there ways we can detect it early? And are there ways we can improve the process of screening here in Canada? And then finally, well, I'll talk a little bit about this as well. Once a diagnosis has occurred in terms of tertiary prevention, how do we understand how we best prevent recurrences and prevent mortality events? And so we've been trying to work on research across this framework. I'll highlight a few examples. And what I'll try to do is sort of talk about some of the things we've done and that we're doing and that we're excited about over the next few years to try to provide some answers to the following questions. And so we think these are some of the important questions in early age onset colorectal cancer, but I think that it's really important to have events like this where we understand what are those real patient-focused questions to help improve the future going forward. So in terms of this first component of so I apologize if my audio is not very good. I'm just seeing a comment here. I'll try to turn it up a little bit. So in terms of the first area of understanding and modeling risk, we want to understand what are the risk factors for early age and onset. Are they the same? Are they just experienced at a younger age than they have historically, or are they novel altogether? Can we use combinations of risk factors similar to sort of patient symptoms to understand risk thresholds to potentially change practice for prevention? And are there unique genetics, both germline, so what the patient is born with, and then also a tumor that can be used to understand risk and potentially change the way we prevent cancer? In terms of the screening research, there's a few really important questions. So should population-based screening programs be a target here in Canada? And again, these are all Canadian context research, Canadian context questions. What's the effectiveness, both in terms of the population, but also in terms of the cost of screening? And when is the risk high enough? And so we've been working to address those questions. And then also very importantly, we want to understand, at least in Alberta, how early age onset patients are treated clinically. Do they have the same levels of treatment, less? Is it more aggressive, more in alignment with guidelines? Do they have better or worse outcomes in terms of a patient given the same treatment modalities? Do they experience the same levels of outcomes? And then also try to use data to understand what are the best optimal treatment strategies. What are the things we should be recommending for future patients? So I'll try to address what we're doing in all of these areas, and we have many others underway, but I'll just focus on these for now. So starting on this first piece around primary prevention, so what is the research actually doing? We're working to understand and model differential risk in the population. So using large volumes of population-based data collected from questionnaires, from clinical variables, from genomics and biological measures, apply some analytics and potential machine learning algorithms to try to understand who's at increased risk and who is, what are sort of normal. Oh, sorry, just looking at the chat here. So not trying to understand who's at increased risk, who's not at increased risk. And so to set the stage for this work, we try to understand what are those risk factors by conducting a systematic review of the literature to understand and examine those risk factors. So we've been summarizing this evidence-based qualitatively and quantitatively through a process known as meta-analysis with the goal to identify gaps in the literature that we can use to expand upon and try to understand through future study. So this just to show that we took a very rigorous approach, methodologically valid approach to understand all of the totality of the medical evidence on risk factors for early age and onset colorectal cancer through a rigorous validity framework, identified all of those studies that have looked at this problem to date to be able to synthesize and put them together. So through this work, we identified studies that included a summary of about 48,000 different patients over the past 30 years from mostly Western countries, so the United States and Europe, and working with a few sort of unique study populations, particularly in the United States, to try to address some of the questions of interest related to differential risk. So the evidence base we were able to identify was of moderate quality, and so it allowed us to make a few statements about what we know so far for risk factors in terms of the medical literature and evidence to date. So in terms of the factors that we sort of classified into these groups of strong evidence, moderate evidence, suggestive, and emerging, so the strongest evidence is for a family history of colorectal cancer, as we heard earlier today. There was moderate evidence. When we say moderate, it means that there's relative levels of consistency across different studies, but it suggests a significant increase in risk when you combine them. So that's gender, excess body size, and alcohol consumption, suggestive evidence for differential effects by ethnicity and cigarette smoking. And perhaps what I think is the most interesting and what we're hoping to carry going forward are these studies where they're emerging. So a large number of studies where they had consistent findings or was in one study that's worth following up on in the future. And these include things like comorbidities like diabetes, ulcerative colitis, hypertension, metabolic syndrome, and chronic kidney disease. And these are potentially relevant for the clinical perspective when talking about which patients potentially should be referred for screening. Some lifestyle factors that reflect our current environment in the world around us. We sit all the time now through various Zoom calls and things like that. Processed meats, insufficient fruit and vegetables, and other dietary factors. There's a few micronutrients and potentially low-cost multivitamins, aspirin use, beta-carotene, vitamin C, and so forth that all seem to potentially lower risk, and a few occupational exposures, including organic dust. But the take-home message from a lot of this was that really we need to do a lot more studies. There's a lot more high-quality studies that are required, and we need to do this on prospectively collected data. And a lot of these studies just looked within early onset patients. So they didn't compare risk factors between early onset and later onset. And this is a really important point because it allows us to understand, is it that they affect them differently? Or is it that it's just the same effects across age groups and we're just experiencing that at a younger age? And also a lot of these studies were using previous older data. And it's likely that there's novel exposures and exposures that are unique to recent cohorts. If we reflect back to the early 1990s, a lot of the way we live our day, the technologies we use, the way we interact with our environment is exceptionally different. So I think it's really important that we start trying to understand some of these novel patterns of life and novel exposures on outcomes. So here in Canada, we are working with the Canadian Partnership for Tomorrow's Health, the CanPath project, that will allow us to look at this question in cohorts of over 300,000 Canadians across 8 different provinces, where we're looking at this with detailed exposure data to evaluate these potentially novel relationships, where it's linked with population-based cancer registries and clinical data, and some linkages with tumor banks are underway. And so we'll do this and we'll focus on Alberta, Ontario, and British Columbia, and we will examine the associations of these potential risk factors with the development of early age onset colorectal cancer. We'll also be able to compare the magnitudes of these associations. So are we seeing the same effects in earlier versus later onset colorectal cancer groups? And very importantly, we'll be able to identify combinations of potential risk factors that are associated with the highest risk of developing early age onset CRC. And why does this matter? Well, we can identify potentially some individuals that physicians could recommend based on these combinations that they may or should be eligible for screening because the risk is so high based on these combinations, not just one particular factor. And as we heard from the previous presentation, we'll be working with some of these international pooling projects led by the American Cancer Society to try to contribute to this global and international research effort. So moving from the sort of modifiable risk factors or the individual level risk factors, we also want to understand and model the risk of early onset colorectal cancer from the genomic perspective. So we know that approximately 30% of these patients have a family history of CRC in a first degree relative. And we know that 20% of cases are affected by some type of a germinal mutation with a detectable hereditary condition like Lynch syndrome, FAP, MAP, or NAP. But importantly, 70% of patients have no hereditary basis for their cancer. So we're trying to work to understand how the genome and the exposome, so what we're exposed to, interact to increase our cancer risk. So we also know that these early age onset tumors compared to later onset tumors are more likely to have microsatellite instability, have higher levels of relevant mutations, more instability with the actual chromosome of their tumors, and when we look at them from molecular subtype, differ from later onset tumors. So this tells us two things. It tells us that somehow the baseline biology of these individuals is interacting with their environment differing in a different way than in older age groups. And this, again, just helps us to understand or requires us to understand more the way that our genomics impacts the risk of developing these cancers. So what are we doing? So we're working to understand this underlying biology of the sporadic EAOCRC, so not the hereditary known cases, to understand how these novel exposures are implicated in this etiology through what are called mutational signatures. And this is work that we're doing in collaboration with a group in Australia and Melbourne. So we've sequenced over 100 tumors with the process known as whole exome sequencing. And what this is basically you're sequencing the entire coding region of the human genome. And we're looking at different types of mutations, types of gene-specific mutations, and we're looking at mutational signatures. And so mutational signatures, which means that we're looking for different combinations of these genomic alterations in the frequency and the type and the context of them. And we can actually look at these and we can tell them what the patients were exposed to. And so we can tell that if a patient was exposed to a given exposure based on their actual genome. And why does that matter? Well, it potentially allows us to identify novel exposures through looking at the genome. So it's a pretty unique approach. It's pretty high risk, but we're hoping it will yield some very interesting and novel findings that we haven't been able to uncover through sort of standard epidemiologic studies. So all that to say that we are very much engaged and very much active in primary prevention research here in Alberta and here in Canada. There is some established evidence that modifiable factors are linked to this development, but we really need a lot more studies to understand, and most importantly, identify novel risk factors. So not just understand what's known about previous risk factors, but understand what's changing in our environment, what might be driving these dramatic increases in risk. We need to do this using innovative study designs and analytics to identify these exposures that hopefully we could, in a timely manner, identify some potential ways to understand and then eventually reduce our risk. So in terms of the secondary prevention, so moving from the risk reduction research to early detection and screening research. So just as a context, I'm sure it's not anything new, but the general paradigm for colorectal cancer screening in Canada is that adults aged 50 to 74 without a family history of cancer are screened using either a FIT test, which is then followed up by colonoscopy, or in some cases, flexible sigmoidoscopy or colonoscopy. This is then identified polyps. These are then identified and removed to allow for earlier detection and treatment, with the long-term consequence being reduced incidence of CRC and reduced mortality in Canada. This has been a very successful program, and this is really the reason why we see a lot of those dramatic decreases in the 50 to 74 age group for average or later age, average age colorectal cancer. So the question is then, well, okay, if it's working amongst 50 to 74, well, is 45 the new 50 in screening? So this is a very important question, the discussion, or the point of a lot of discussion in the literature. And so what we've seen elsewhere, so outside of Canada, to set the stage, so in October of 2018, American Cancer Society made a recommendation for lowering the screening age to 45. This was sort of similarly mirrored by the Cancer Council of Victoria in 2018 that made a recommendation for lowering the screening age to 45. And this was then followed up by a recommendation in action from the U.S. Preventive Services Task Force in October of 2020. That has now been updated as of about 3 weeks ago. The U.S. Preventive Services Task Force has made a final recommendation to reduce the screening age to 45, which brings with it the implication of coverage for private insurance, also public insurance to pay for that screening. Of course, that context is very different than the Canadian situation where we're a single payer healthcare system, so has a very different cost effectiveness implication. And so the question is, what is the difference between the risk between those 45 years of age and 50 years of age? And so what we see here, these are male shown on the left and female shown on the right, and these are the incidence rates per 100,000. And so the red line is the rate between of males, for example, on the left, 50 to 54 in 2000 when population-based screening started, and the blue line is the trends over time in the age group of 45 to 49. So what we see is that the rates are still not there. So rates are still not as high as they are in the 50 plus age group. And so before we can make any recommendation in Canada, when we consult with all of our clinical colleagues, there's a few really important questions we need to answer going forward. So we need to understand the trends in histology, topography, and mortality. We need a detailed analysis of cost effectiveness that outlines the impacts of the current screening programs with potential harms and benefits. And moving back to the previous topic, we need to have an understanding of risk factor profiles that may lead to meaningful recommendations for screening decisions within that age group in the absence of a widespread screening program. And also we need an evaluation of the effectiveness of current and novel screening tests or biomarkers, specifically in this age 40 to 49 group. And so we really set out to answer a lot of these questions. So what are these questions beyond incidence? So the topography, histology, stage, and mortality. And so we've been looking at these questions as well in a detailed way, trying to understand, is it any particular area of the colon where we're seeing these divergence in rates? And it doesn't seem to be the case. We seem to see similarly alarming trends in areas that would be detected by screening, which is why we're sort of concerned about topography, because it's not equal distribution of detection across the colon. There's also the debate around histology. So a recent study in the United States suggested that carcinoid tumors, which are not the targets of screening, and they're managed very differently than carcinomas, are the ones that were increasing, and that there actually isn't really a cause for concern among the younger age groups. So no study had looked at this previously in Canada, and so we see that that's not the case, that the increases in rates in this top line, which are non-mucinous adenocarcinomas, they are the ones of clinical concern, and they're the ones that are detected by screenings. So there is definitely cause for concern. We also wanted to look at stage at diagnosis, and so we heard that generally it's believed that those at younger ages are diagnosed at later stages. And so we looked at these data, and this is across all of Canada. So this is all cancers diagnosed over the last 10 years. In Canada, when we look at younger age groups for colorectal cancer, so these are odds ratios. And so having a number greater than 1 says there's a higher probability of the event happening. And so this says that those in age groups 30 35, 40, and 45 are at much higher probability of being diagnosed at a later stage, so stage 3 and 4 compared to the average screening age. So this 50, 74. So there definitely is the cancers that are being detected under younger ages are potentially detectable by screen, and younger age groups are being diagnosed at later stages. So there is a value to potentially evaluating screening in this population. Screening might make a difference clinically. And then in terms of looking at trends in mortality in younger age groups, we still do see an increasing trend in mortality for early onset patients. And why does this matter? Because that's the end goal of screening, is to reduce mortality. And if we didn't see the corresponding increases in mortality in an early age and onset, then we would have less of a potential target to improve with screening. And so this is showing the females here shown in the top 2 panels, male shown in the bottom 2 panels. And so this is basically looking at within rectal cancers, but all colon cancers. We see that there is dramatically increasing mortality rates for both males and females over the past 20 years in Canada for rectal cancer. So to bring us all home, so is 45 the new 50 in CRC screening? So we think that you really can't use, sorry, I think I'm having some connection problems. Let me just pause here for a moment.
Hi, Dr. Brenner, it's Anne-Marie. We're here to help you. Your internet's been going in and out a little bit. It's not horrible, but we're just getting some feedback. Would you like to continue or go onto an audio line?
I just tried the new link. I'm going to drop off this call and start a new one.
Okay, great. To all of the participants out there, apologies for the small break. One of the I think for all of us who've been on these virtual sessions many times over the past year or so, we do know that internet connections go in and out. So we've got lots of backups here, and we'll get Dr. Brenner on with an audio call. I encourage you to ask any questions that you have through the question manager at this stage. The data is rich as it's being presented currently. Give him just another moment. To the Resolve team, perhaps what we could do is take a quick break at this stage. We'll come back in 5 minutes, or have we got everybody?
I'm just wondering if this is any better.
Great, okay.
Can you hear me now?
Yes, we can sure hear you. Thank you.
Excellent. Okay, hopefully that the new link resolved the issue. Apologies. This is the world we live in.
No need to apologize. It's the world of the internet. We can't predict. You've done everything possible. Everyone's done their very best to make it happen, and here you are, and it already looks a whole lot better.
Excellent. Okay, so I will keep rolling then, and I apologize if I was distracted, because I kept getting messages saying that people couldn't hear me. So
yeah,
we'll
Okay.
Here. So to bring us back to the point, basically So we know that screening might help in the sense of the epidemiology of the disease is suggestive that screening might help, but the problem is a one size fits all might not be relevant because we would have increased wait times. Colonoscopy is not at all without complications. There's a risk of a perforation happening about 2 in every 1,000 procedures. So what we need to do is come up with some sort of smart ways to stratify the population to know when is the risk high enough. And so as I showed before, so we know that what are the individual factors that would make someone's blue line match the red line is really what we're trying to do with data. And there's probably some combinations of symptoms, of comorbid conditions, of personal characteristics, and of lifestyle or behavioral or environmental exposures that push someone's risk up from that one level to the other. And so what we're trying to do, we're trying to say, well, age is just one risk factor, but it's probably multiple risk factors that make the rest of it. You have someone's actual cancer risk. So what are those multiple risk factors? So again, we're putting together lots of data, individual level, from questionnaires, biology, genomics, to understand sort of what are those people who, yes, probably should be screened earlier, either 40 or 45, and those who are at lower risk and who likely could avoid screening and avoid the potential harms of additional screening. And we're doing this through some studies here in, as I mentioned, the Canadian Partnership for Tomorrow's Health study. So what we'll do is we'll create simple tools using demographic data. If cases are sufficient, we'll create prediction models for colon and rectal separately, and then we'll expand this out to hopefully test and implement with physicians. So the end goal of all this work will hopefully be some useful materials for clinicians to understand. So really, in terms of what we're trying to do here in Canada for early age and onset screening, we know that changing the recommendations holus bolus would increase the number need to screen, would increase already finite demand for colonoscopy, and would increase the numbers of colonoscopies that would have to be used to be effective. So really, we're going to try to focus on developing some risk-guided approaches that are based on someone's 5-year risk to identify effective and potentially cost-effective strategies for population-based screening. And lastly, just thinking about what are some of the active ongoing research in Alberta to understand and model and improve outcomes in this tertiary prevention space from the treatment and survivorship component. So what are we trying to do? We're trying to understand with data, so be it clinical variables, be it genomic or biological, to understand which patients respond best to treatment. So we know that there are some relatively comprehensive national comprehensive cancer network treatment guidelines, but these aren't necessarily specific to any population age group, and there's not an entirely clear level of certainty for all of these groups. So we've covered it here, where there's a relatively low level of certainty of how these treatments work in early age and onset. We heard in the last presentation about patients trying to get on trial in this specific population because there is, in quite a few different subgroups, a low level of certainty in terms of which are the most optimal treatments to give. So we really don't have official guidelines for this management of colorectal cancer. So what we know, though, is in the real world, patients tend to receive, or we're told that they're potentially tend to receive more aggressive treatment. We've seen from the other studies that they have more lymph nodes examined at the time of diagnosis. They're more likely to receive adjuvant chemotherapy, radiotherapy, and more likely to receive multi-agent therapies. And so this is all data that was largely coming out of the US and Europe. So what we wanted to do was examine some of the studies data here, studies here in Canada. So we started a study in Alberta to look at patients treated from 2010 to 2018, compare the patterns of treatment in the average age, so 60 to 70 age group, and compare the outcomes to the early age and onset. So what we see is that we have a higher preponderance of rectal cancers diagnosed in the younger age group, and we have much more advanced stages diagnosed in the younger age group. So here we have it broken down to under 40, 40 to 49, and then comparing that to 60 to 70. So anecdotally, we have seen elsewhere that at the time of diagnosis, there are worse markers of disease, and that is the case as well here. We also see less comorbidities among these younger age groups, and so that may be one of the reasons why treatment tends to be more aggressive in this population. So when we look at the actual treatment characteristics for these patients, so these are early stage patients, so diagnosed at stage 1 to 3A. And so again, these are odds ratios, so the probability of being diagnosed or treated at a given more treatment. If it's above 1, it's a higher probability. If it's less than 1, it's lower probability or lower odds. So in this case, younger patients, so 40 to 49, are more likely to have greater E nodes examined at the time of diagnosis. They're much more likely to be given chemotherapy in the early stages and also be given chemotherapy in the early stage 3, and be likely to be given chemotherapy and radiation therapy for both colon and rectal cancers. So they're treated sometimes perhaps more aggressively compared to 60 to 70-year-olds in the early stage. In terms of advanced disease, so typically the younger people are diagnosed with higher numbers of metastatic sites, and the sites sort of vary by age group. When we look at how they're treated in the late stage, so the darker sort of things are highlighted to draw your attention, but what we see is that typically in the later stage as well, stage 4 patients are given higher proportions, are given systemic chemotherapy, and are given more aggressive types of chemotherapy in the advanced stage. When we look at how this translates into colorectal cancer specific survival, we see that in the 40 to 49 group, actually they tend to do better. They have better survival outcomes than the older counterparts. So in terms of comparing the 5-year survival rates, and in terms of comparing the median survival, so those treated 40 to 49 tend to have better outcomes in Alberta, at least, than those in the 60 to 70, 80 group. So in terms of what we see for modeling and improving outcomes, so early age and onset patients tend to receive more treatment in Alberta, but we don't really have a good understanding of the comparative efficacy for the different treatments. And so we think this is a major research gap we're trying to work to identify or to fill, is identifying the optimal treatments for early onset patients in early and late stage. We're also working to develop some prediction models to help clinicians and help patients make decisions around who would benefit from specific treatments, to try to balance the decision making with potential side effects, so that there can be some shared informed decision making with using patient level data. And so to conclude, so we know that there's a very complex story happening here in terms of the risk factors that increase or decrease risk. There's lots of additional work to be done to understand novel risk factors, both environmental and genomic. And these also then will help us sort of understand this underlying complex story. In terms of screening, we know that a blanket recommendation is not likely to be cost effective, but there's lots we can still do and are working to try to do to help physicians improve that gap we heard in the previous presentations about the long-term period from symptoms to diagnosis. So use data, understand risk to try to be better informed and help improve screening and prevention. And we know that we need to have better follow-up studies in this third space to identify what are optimal treatment strategies. And we have a few projects underway right now to best understand, to help clinicians and help patients be better informed about what would be the best treatment strategies specifically in the early age and onset population. So this is all work from the Canadian context. We're really excited to be working in this area, and we hope that our research eventually turns into some patient level impact. So stay tuned, and we hope to have more to come. And again, I apologize for the connection issues.
Yeah. Dr. Brenner, no need to apologize. The data, the content was superb, enlightening, and extremely valuable. So thank you for making your way through under not so easy circumstances all the time. We just have one question coming, and I think it's really it's the big question that everyone is asking today. Is 45 the new 50 in colorectal cancer screening? And should actually colonoscopies be offered as a screening option to patients in Canada? So I'm going to just leave that, ask if you could comment on that, provide your final comments, and then we'll move to break.
Sure. It is really the question of the day. From our research right now, offering everyone colonoscopy is probably not cost effective, and you're probably going to have lots of individuals potentially expose themselves to harmful procedures. But with that said, I think there's a middle ground where if we can have an informed discussion about the potential harms of screening, and then maybe use FIT test and allow FIT to be offered to everyone as a primary index test. And then if the FIT is positive, then go for colonoscopy. I think that's the sort of next natural step in terms of modifying guidelines as risk continues to increase. And so I think that in combination with identifying some of the patient symptoms and patient characteristics that can really be used to help identify those people who would most benefit from a FIT test and then a colonoscopy. And I think that's probably where we're going to get to, and I hope we can get to.
Yeah, thank you so much. I also wanted to just shout out to your comment about limited studies in Canada on young adults. And of course, that's a great segue and referral back to the International Research Symposium that is being run in the US next week. Thank you so much, Dr. Brenner, for coming in.